Thank you for having me. Excited to talk a little bit more about my areas of expertise. Yeah. Basically, I grew up in a family of a lot of medical professionals. My mom was a nurse, my aunt was a nurse, my grandma was a nurse. So, I was always thinking as a child, okay, well, that's where I want to be. I want to help people. And that was just the first sort of taste of being in the medical field and what that would look like. And then through time, I kind of found myself being put in this role of the listener in the friend group. And people would turn to me and say, you're a great listener. I'm having this problem. Can you assist me with this, or can you just listen? And so through time, that interest in helping people evolved from, okay, I definitely want to be in the medical field to, well, wait a second, what is psychology? What is, being a therapist, being a counselor? So through high school, I sort of explored that area, and decided that, I really would prefer to go the route of psychology, and being a therapist. Um, had some life experiences too that I think just confirmed that that's what I wanted to do in terms of, um, I have a brother who has dealt with addiction issues, for much of his, I would say, much of his teen to adult life. And so while he was going through those things, I was in that area where I'm like, what do I want to do with my life? And so, seeing how others would work with him, I really got the sense of, I think I could do this. I think this is something that, I think that I could be good at, and I think that I can help people. So that really reinforced the interest, and then it just sort of took off from there. Went to school for psychology, immediately went for my master's and my license afterward, with, the ideal being I would love to be in private practice, at some point, working with individuals who, um, are struggling with a whole host of different issues, which is where I've come to learn that anxiety, eating disorders, and other areas related to those, and trauma, because those all really fit together. That's really where I found my interest to be. Yeah, absolutely. So that was something that I felt like was crucial based on my experience, professionally. So professionally, I've been all over. So I started off my career working with kids, actually, working in a wraparound system with kids with behavioral issues or autism or things of that nature. I moved from there to do some outpatient work, for a nonprofit organization. And then I moved to a residential, eating disorder facility. So, um, as I moved through my professions, there was one thing in common, was trauma. I'm seeing individuals in all areas of life. I saw kids that were currently, in traumatic environments. I was dealing with women in an eating disorder facility who, 70 probably to 80% of them, were there, and had histories of trauma. So to me, it was a must. It was something like, I want to further my education in this area because this is what I'm seeing across the board with individuals. And I really just wanted to have that additional layer of expertise in terms of, how do I talk to people about this? What are some skills, that I can take from this to work with my clients in the future? And I think that's a great point because, I also think in society there's this big push to be quote strong, right? To face your adversities, to get through it, and I think male female I think that message is out there of like you just deal with the things that happen to you and you just get through it and you don't need to necessarily seek help or you don't need to do these things or harp on it. um, but that we know that that's not the case, right? So we refer to trauma. There's big T. So for trauma, there's big T trauma and then there's little t trauma, right? So when I'm talking about that, big T traumas might be those events that most people think of as traumatic. So, you know, um, being sexually assaulted, witnessing, some sort of brutal event. Those are things that I think the majority of people would consider traumatic situations. But we also have to realize that, trauma is individualized to the person. So, something that John Smith might think is not traumatic or to him is not traumatic might be a totally different scenario for someone else, like bullying, for example. Some people don't necessarily consider that traumatic, but other people that affects them for the rest of their lives and leads to all sorts of other, you know, um, issues with self esteem and all of that stuff moving forward. So I think it's important that, you know, we don't just look at the big T trauma events. Like we need to know the person, um, and we need to be able to talk with them and say, like nothing is too small, to be considered a trauma. And I think that's what we try to do in therapy is say, like, we're not judging you. We're not saying, your trauma is a 1 on the scale of 1 to 10. If for you it feels real, and you have some sort of reaction to it, then that's trauma. Yeah. Yeah. Yeah, and I think and the key there is, what is their reaction to it? When we're talking about trauma, there needs to be some type of reaction that the body has, reaction that your mind has that is causing you to feel stuck there, if that makes sense,
Mhm.
right? So, the event, even if it's relatively minor, again, it's a small t trauma. Like if that person's experiencing hypervigilance, there's some paranoia involved, or there's things that have manifested physically, then we're looking at, okay, well then that is actually a traumatic situation for that person. So I think you have to look at, how is that person affected, because as we know, like trauma does live in the body, like the body remembers these things, you know and it obviously affects our minds as well, because there's different symptoms that we get there. So I think we need to look at, like if this is trauma, then it is definitely affecting you in some way, mentally, physically, emotionally. There has to be something there. If those things aren't there, okay, then maybe we work with that and say, that was a distressing event for you, and deal with it in that term rather than a trauma term. Yeah, yeah, and I think that's what really is the goal working with any trauma is, depending on, again, what the traumatic event was. Like we don't want people to think, well, oh, I can go through that huge big trauma again. But it's like, let me learn the skills that the skills that I need to get through that trauma. And like, can I then translate those skills to other distressing events that happen to me? Yeah, absolutely. Yeah. I think it's a skill set. It's an awareness of your body. It's an awareness of the symptoms that you're experiencing. Yeah, yeah. Trauma basically like it takes over the brain. So there's something called like the fear circuitry, basically. So what happens with traumas a lot of the time is your prefrontal cortex, that's in charge of making decisions, executing, stuff like that. Basically, this fear circuit sort of interferes with that ability for that prefrontal cortex to work the way it's supposed to be. And that's why you may hear that people freeze, during trauma or, the fight or flight. Like that's a real thing that occurs during trauma. And a lot of the times we've heard more recently about sort of this freeze response. So what's happening here is, you've got this fear response taking over your ability to almost take action, make logical decisions, kind of get through that situation like you would in any other normal task where you're trying to solve a problem. Um, and then the when this happens, it's taking its toll on the brain. And it's if you think about repetitive behavior, the more times you feel this way, the more times this tends to take over the necessary things in your brain don't function. It it kind of becomes ingrained. Um, the more times this happens, your brain starts to adjust to that. So that's why people talk about the fact that trauma changes the brain because it actually does. Um, your prefrontal cortex is not operating the way that it normally should. And instead, fear is almost covering it up and taking it over. Yeah, it's fascinating. I think a lot of it, like, what is that person's support system? How are they seeking help? Addiction is so genetic, and my brother's not the only one in the family, that has had addiction issues. So, there is a history there. And I think it's like I said, are you recognizing it to be a problem and what are you doing in terms of action from there, right? Um, he got so deep into it that it was, you know, and he never got help for it. There was never a time where he sought help for it. He also didn't seem to have a great support system in terms of people telling him, you need to do this, we care about you, and stuff like that. He didn't have a whole lot of friends. Um, so I think that plays a huge part too. Like these things you can be predisposed to, but how are you utilizing what you do have to almost protect yourself? Like, what are the protective factors? And are you using them? Yeah, great question. The biggest one, obviously, that comes to my mind is eating disorders. I mean, eating disorders in itself, if you really break it down, is an addiction of the food that you consume, and or how you may get rid of that. Um, so, that is sort of the biggest addiction that comes to my mind. But there's so many out there. Some people have addictions to like being in the sun, like some people have addictions to, video games. Some people have, that's a little bit more known. People have addictions, gambling is another one. These are all things that people get some type of pleasure from, which is why they continue to keep doing it. It hits that dopamine center and it's like, okay, like I need to keep doing this thing and now I need to keep doing more of it so I can continue to feel that good about it. And so then you may be thinking, well, eating disorders, like how does that make a person feel good? Well, I mean, if you think about it, yeah, if you're restricting your food, if you're purging, if you're over exercising, that immediate action may not feel good, but it's like the after effects of, okay, I did this good thing for myself because they perceive that they're doing something that makes sense, that's good for them. So, it may be hard to see why that would feel good to people at first because the action of, purging is unenjoyable, but they're getting something from it, which is why they continue to do it. They get that good feeling afterwards. Yeah, yeah. Because the thing with binge eating, or again, just overeating in general, the whole entire process is enjoyable to them, right? So it's not just what you're saying of consuming the food, but like, I've worked with individuals with binge eating disorder who take pleasure in the going out to the grocery store and the purchasing of those things. So if you're saying to somebody, wait, don't do that part of it, like that's almost impossible because that's basically saying, well, get rid of your eating disorder, right? Because that's part of their enjoyment and how they prepare everything for what they're going to do. So instead of maybe something like that, um, I would maybe like work with them on changing their routine, right? Don't even talk about the food shopping, what you're doing. Like, let's maybe get some activities planned at night, if that's when you tend to do these things. Let's try to be proactive to maybe plant some support, like, or change your routine or add something in that gives you pleasure, so that you don't sort of fall back to the routine of engaging in that eating disorder. Yeah, routine. Yeah, they can definitely begin at any time. However, I would say a lot of it does trace back to childhood and just things that were going on in the house revolving around food. Um, if again a child is sitting in front of the TV and the parents keep giving them snacks, it's this mindless eating that we're talking about that can occur at a very young age, and they don't really, have the wherewithal to know what they're doing or that it's not healthy, right? So, a lot of this stuff does develop during childhood, but it could also develop at any point. Um, I've worked in a university setting and that can be a huge triggering time for people because they're independent, they're on their own, and it's like, wait, how do I manage my meals? Or like, do I have enough money to get these things? And so that's a huge point where we see eating disorder percentages increase. Um, we also are seeing it a lot in adults who are older, who are retired, who again, it's like a shift in routine. Um, and they might turn to unhealthy eating, whether it's restricting, whether it's binging, whether it's something else. You think of the big life changes, and that's where you typically see a lot of the increases in eating disorders. Good question. You know, the disorders are so different, but basically, it's all of them concern a manipulation of food intake. So I think to make it very general, an eating disorder is somebody manipulating or controlling their food intake, um, you know for some gain for them, if that makes sense.
Okay.
So yeah, I don't know that there's a clinical definition, but that's what I would say. That if somebody's having an issue and they're trying to manipulate what they're eating or what they're doing after they're eating in regards to the food, then we're talking about an eating disorder. Yeah. Um, I think it really depends based on which eating disorder it is, but there are some that are in common. So, if we're talking about individuals who, avoidance comes into play a lot. So if you have a friend or somebody who's always excusing themselves, maybe from going out to dinner with friends, or sort of doing those things, you again, that doesn't equal eating disorder, but it's an eating disorder behavior where you're trying to avoid being out with other people that are eating because you tend to want to just do it in the comfort of your own home or where you are so you can manipulate what you're doing. So if somebody's avoiding, if somebody's hiding food, that's another thing. That occurs very frequently with binge eating disorder, where individuals will hide food in their bedrooms, stuff like that, to have easy access, but access by themselves that nobody knows about. Um, Other things, in common, really, there's typically a self-esteem, self-image component. Now, I wouldn't say 100% that's the case, but that's in, that's definitely something. If somebody has low self-esteem, low self-confidence, low, not a great image, great body image, that's going to be something that could potentially trigger an eating disorder. Yeah. So the first one that came to my mind is there's a lot of people with eating disorders do food rituals, right? And so there are things that they may do with their food, um, that is not the norm, but it's also very difficult to notice potentially. So, for example, having to cut your food into 20 pieces before you eat it. Or, you don't use certain utensils when you eat. These may not be things that are easily picked up by people, but there are these rituals that people, and it almost seems like obsessive compulsive behavior. It's these things that people have to do with their food in order to either feel comfortable actually eating it or they're delaying the process of eating it. Okay. So that's the first thing that comes to my mind that a lot of people do, and it's definitely a symptom of an eating disorder when you're doing some of these things with your food, that other people may not do. um, Trying to think, so other things that you might not notice as an eating disorder, there's something now called ARFID. It's ARFID, and it's avoidant restrictive intake, food intake disorder. This is a relatively new diagnosis where individuals, and it's typically a sensory issue. So people may say, well, I can't eat that food because I don't like the texture of it. I can't eat tomatoes because I can't stand eating seeds or whatever it might be. This is now an actual diagnosed eating disorder where people will avoid large, not even food groups, but just random foods because of a sensory sort of component. Like they don't like the skin on something and, like all of that. So that before was never really recognized. It was just like, oh, maybe that person's a picky eater, right? Or they just don't like that particular thing. And that was a little bit more accepted. But we're seeing more of that being an issue for people where, you know, because of that. And then they also then have the fear of like, oh, am I going to gag on this thing because I'm eating it? So it's a whole thing, but that's been, something that's newer that, people should know about that. Like if you're really struggling with the texture, the sensory, um, experience when you're eating certain foods, like that can lead you to completely restrict a lot of things. and that could lead to malnutrition. Yeah, yeah. I imagine like I'm thinking of, somebody that I used to work with where there were only certain things available in the home. So this particular client, would have access to all of these or certain things. And then later in life, when they were exposed to like other kind of textures of food, they were like, nope, it was like rejected, So I think it does have a lot to do with like when you're young, like what do you give your child? Like what access do you have? Like, if a child likes a certain thing, are you trying to get them to expand, their taste really, or are you just sort of giving the child what they want and what they're used to all the time? I think that could be, something that triggers this type of thing. Um, or completely away from that, a lot of people may have one bad experience with a food in particular, and then they're like, okay, no, I'm not doing that again for fear. Again, that's where the anxiety comes in, for fear of, I may gag, or I may vomit, or I may, my stomach may not feel well. And that's where some of the stomach stuff comes in too, is people tend to take one or two bad experiences and then put that label on it of, okay, I can't eat that thing. I can't eat that food. I'm not going to do that because I don't want to put myself through that. Yeah. So, firstly, like eating disorders have always been considered a female disorder, and I think that's wrong. You know, eh, I feel like there's a lot of pressure on men these days. Um, Again, and this will also go into other countries too, but the social media stuff where men are sort of expected to look a certain way, look in shape. The more muscular sort of build is preferred. So I feel like unfortunately men are really like overlooked here because there are ideals of what men want to look like, um, and so they may restrict. They may overexercise, which is what I was just talking about, to try to get to that. So whereas this was always considered like a female thing for so many years, like I'm finally glad to start seeing that there's more facilities opening up that treat men too, because it's a huge thing. And to go to your question about other countries, the more westernized the country is, the more you're going to see the eating disorders. There's that correlation there. So, like, you look at China, Japan, um, Russia was high up on the list of individuals with eating disorders. I think France was up there. Like, the more, I would say, urbanized, westernized countries have that sort of increase in the eating disorders because they have more access. The more access people have to social media, to um, stuff like that, that kind of tell you what you should look like, that's where you're seeing the eating disorders. So other countries, absolutely. A lot of the Asian countries have a significant amount of eating disorders that happen. And that's because of their access, really. Yeah, when I worked in an outpatient nonprofit, I saw an eating disorder at, oh, the girl I think was maybe 7 or 8,
God.
and that was the youngest that I had seen, but we're seeing it earlier and earlier now. Like, it's, again, I go back to the access thing of, if parents are letting their young children on these social media sites, everything is out there, and everybody is getting the praise for looking thin, or all of this stuff. All of those people have all the followers, and who doesn't want to be popular, right? So then these young females and males are looking at these individuals and saying, okay, well, that's what I need to be like. And from a young age, like, think about, like, the brain's not fully developed at that point, so they're not maybe able to really reality test so much there. And they start to sort of engage in these things. And, like, they're talking to their peers about it, even at young ages. Um, so, I would say by, like, I don't know, third, fourth grade, like, you're starting to see some of these things that we didn't initially think was happening until much later. Yeah, yeah, and, what's interesting is actually, my daughter is school age, and, they have now actually built in a health and wellness, um, special, or like a, it's in their cycle of classes that they get. So, once a week or once every, 6-day cycle, they have a health and wellness class where she's actually told me that they talk about, like, like eating, how you kind of feel about your body and stuff like that. So, you know, I, I like that idea, and I think it has to happen. The sooner you start having the conversations, the better. Even if they're really young, start having the conversations about food. What is food used for? Food is energy. Food helps you. Like, let's start to have a good relationship with food from the get-go, rather than um, allowing social media to dictate what kids know. Correct. Yes. Yeah, yeah, and this is a very, it's a subjective sort of thing here. But what I would say is, um, anorexia has the highest mortality rate. So I'll start with that. So, when we're talking about anorexia and we're talking about higher level of care, we're talking about, obviously, somebody who's low weight. The DSM changed their criteria, the last go round, to basically say somebody who is low weight, and they didn't specify a percentage. Um, but when you hear about eating disorders, a lot of the times you will hear about percent of ideal body weight, IBW, or you might hear BMI. I prefer IBW, but um, if somebody is, you know, underweight, um, and they're restricting their calories to, like, I would say somewhere between, like, 1,000, somewhere around that or lower, we're talking about a problem, because at that point you're going to be losing weight continuously. We're also talking about somebody needs a higher level of care if there are medical concerns. With anorexia, um, heart rate is a huge thing. So bradycardia, like, if your heart rate is low, we're talking about the fact that not eating is putting that pressure on your heart. So and really across the board, um, anytime there are significant medical factors involved, those need to be closely monitored, in a hospitalized setting, whether it's a residential setting or an inpatient facility, because you don't want to mess around with those things. You don't want to mess around with heart issues. You don't want to mess around with electrolyte imbalances, because when you start refeeding your body, your body goes out of whack because it's not used to it. So you need to be medically monitored. So I would say the first thing is those medical things I just mentioned. If those are off, without a doubt, I'm looking at somebody that needs to be medically monitored, and that means inpatient. Um, with anorexia, like I said, low weight. Um, I mean, we're talking, it depends, on what the person's weight is, but, we're talking about somebody that is pretty significantly underweight and has no motivation to change how much they're eating. If we flip over to bulimia, um, you know, it's concerning to me when somebody is purging on a daily basis. If somebody's purging weekly, maybe you can work with that person in an outpatient setting. If they're doing something where they're vomiting multiple times a day, daily, like we're talking about the fact that we're going to get some medical problems really quickly if you don't already have them. So, so I would say, all in all, to answer that question, what I go off of most, which I think is so important with eating disorders, is having, as a therapist, having a relationship with their doctor so that you know what's going on. Because medical issues are the reasons why these individuals pass away. That's why they're so fatal. So if there are medical concerns like electrolytes, potassium, sodium, those things, and heart rate, those are no brainers to me, that you need a higher level of care to be stabilized. And also, too, when somebody's dealing with an eating disorder, their cognitive functioning is not what it would be. So they need to get stabilized. Otherwise, they really can't do the cognitive work either. In a facility?
Hmm.
Yeah. Yeah. So residential settings are pretty much where you have a meal plan. You're basically observed most of the time, and there's a medical staff on hand. Um, when you're in a hospital, they can insert a tube if they need to. It's almost right. In a hospital, it's like force feeding. In a residential facility, it's like a tiny step below that. Um, but there's expectations there too. So yeah, I mean, the worse it gets, the more likely somebody's going to be in a hospital with some sort of tube to feed them.
Two.
Yes. Yes.
Okay.
Yeah. So at the place that I worked, they did family therapy typically weekly, as well as multiple individual sessions a week. It's high. I mean, there's no way around that. I don't have the exact percentage of relapse rate, but when we're talking about the fact that this is an addiction, just like alcoholism or drug addiction, um, oftentimes it takes multiple treatment attempts in order to get well, because this is a learned behavior. Eating disorders are a coping mechanism. They're your go-to of when you can't manage your emotions, when you're distressed. It's like that's your go-to thing. And when you're taking that away, if that person is not adequately given something to replace it with that they value enough, they're going to be right back where they were, or if they don't have the family support, same thing, especially for teenagers or people that live still or live with somebody else. Um, if they don't have that support, then they fall back into the eating disorder as, again, like I said, a coping mechanism. It usually is, yes. Yeah, insurances will cover hospitalizations, and residential treatments. Now, again, most plans, there might be a deductible involved or something like that. But yeah, insurances do cover these types of things. Yes.
Receive.
Yeah, yeah. So, body image is a huge component, and I like to explain it to people as like it's almost like you put on a pair of sunglasses and you're seeing yourself differently, and then everybody else around you is seeing you without the sunglasses. So I kind of use that to explain to people that your brain can kind of make you see certain things, or it makes you focus on certain things. Like there's also a disorder called body dysmorphia where individuals focus on a particular aspect of themselves. So maybe my nose is too big, or, what have you. And so the brain, it's almost like the brain's playing that sort of trick on you. And you need to kind of sit there and say, okay, like I understand that this is what I'm seeing, but it may not actually be the reality of what everybody else sees. It's a very difficult thing for people to grasp. But I use that sunglasses thing to tell people like this is what it feels like. It's a different experience. So to work on like body image and stuff, I like in therapy, it's a long-term thing. Like I work with body image and people like work with people with body image issues for years and years and years. And it's not, let me be positive. That's not always the right approach to take of like, you know, um, if, if you're telling somebody to say, oh, I'm beautiful the way I am, like that might not resonate with them. Like I take more of a realistic approach of like I said before, like let's think about what your body does for you rather than necessarily, the outward appearance. Like, your body is this vehicle that allows you to do all of these things. So, let's take away the value in what your nose looks like, right? Because let's take your body as a whole and like what does that do for you? I've learned that you can't tell people like, oh, you look fine, or oh, don't worry about that, or that just doesn't tend to work. I think taking a more realistic approach of like, if you feel that way, like okay, like understandable, let's maybe challenge that a little bit to get to a better place with that. But what else can we focus on about you, or even about your appearance that like you do like or you do feel satisfied with? It is, yeah.
It's gotta be
Yeah,
hard.
it's hard. I mean, body image, even just self-esteem work as a clinician is really hard because you want the person to develop that internally. You don't want them to be taking, all the external stuff, and then making a judgment about themselves. Like you want them to develop those positive feelings about themselves, but it takes time, and they also need to distance themselves from the things on social media that are making it worse. And again, social media is an addiction in itself. So that's hard too, and that's why I'm saying like self-esteem work, body image, a lot of them, they go hand in hand, and it's going to be, for some people, a lifelong thing that they work on. For others, it's going to take a lot of time. But I would say focus on being realistic, not being negative or having to be overly positive. Like let's come to some middle ground. Yeah, I mean, I would say monitor if you're going to allow kids to be on these sites, monitor what they're on. I mean, there's easy ways to do that, to monitor content on TV, social media, everything. Like there's a lot of good stuff out there, but there's a lot of bad stuff. So just it I would say monitor what your child's doing. Now again, once they get into high school, you do allow more independence and whatnot. But these messages start from an early age. So whether your child is 5, 6, 7, going up from there, like just know what they're doing, and make sure that they are monitoring the content. There's a lot of good stuff and appropriate stuff for kids out there too. Yeah, absolutely. So, I would say the best way to contact me would be through hopestreamcounseling@gmail.com. You can visit our website. It's hopestreamcounseling.com, and you can read some information about me. We also have our phone number on the website, and you can pretty much do a schedule a 15-minute consult, which is free, just to chat with me and talk through what might be going on for you, whether or not we might be a good fit. But that would be the best way to reach me. I do have availability currently. So yeah. Yeah. So eating disorders, like I said, I do work with trauma that's not based, or is not linked to an eating disorder. So I do work with trauma of any kind. I also work with anxiety. Another interest area of mine, being a former athlete myself, I do like to work with athletes who have issues in any area. And how these issues might impact performance and stuff like that. Yeah, and I think too, once you give up your sport, there's also a lack of purpose there. There's, like, what am I devoting my time to? And like you're saying, like people tend to want to do the same workouts and do all of that stuff, and it's like it's not sustainable. So that's definitely an area that I'm interested in working with as well, because I do think it flies under the radar there a little bit in terms of there's not a lot of sports psychologists out there. I'm by no means saying that I am one. I just, have a lot of interest in that area, and working with those particular issues.
Digestion.
Yeah. So this is not something that I've read yet, but this is something that I've been looking into, and it looks like a great resource, and also speaks to what we were talking about today about males sort of being underlooked, right? So the book is called Please Eat. It's a mother's struggle to free her teenage son from anorexia, and it's by Bev Maddox. Um, I this is something that I've been eyeing for a while, but it basically is a mother's recounting of her son's anorexia, and how she doesn't know what to do. Like, do I force him to eat? How do I do this? And worried that her son's going to die. So that is something that I'm really looking forward to reading. And so that's definitely on my list.
Excellent. Excellent.
Other things, if you want eating disorder resources, there's tons of free trainings out there geared towards various professionals. So the Renfrew Center has a bunch of stuff on their website. Take a look at those. They're free. They're geared towards different populations. And there's just the National Eating Disorder. There's a website there, NEDC, that also has a ton of resources. So hopefully that's helpful. Yeah, thank you so much. I appreciate it.
This is a lot of fun.